Welcome back guys. Now in this video let's discuss about reproductive hormones. The two important reproductive hormones that are present in the humans are, in the females there is estrogens. Of course estrogens are also present in the males, estrogens and androgens. Androgens are present mainly in males but also in the females. So these are the two important reproductive hormones that are present in both the sexes. So what is the function of these reproductive hormones? What are the functions of these reproductive hormones? There are many functions which we will discuss in detail, but generally speaking, they help in development of the sex organs. Development of sex organs. Okay, and also helps in development of sexual characters, secondary sexual characters. Okay, secondary sexual characters like the axillary hair, the pubic hair, okay, the voice. These are the secondary sexual characters that will be developed because of this sex hormones. Now, first let's discuss about the estrogens. How many different types of estrogens are there? In females, there are actually three different types of estrogens. Okay, three types. What are the three types of estrogens? One is estradiol. Estradiol. Okay, estradiol, two alcohol groups are going to be there. Estradiol, which is most potent, out of all most potent. Okay, first one. Second one is estriol. Okay, three alcohol groups are going to be there in the structure. Estriol and estrone. Estrone, ketone. Okay, ketone group is going to be there. So these are the three types of estrogens which are going to be present in the females, and the most potent one is going to be estradiol. Okay, estradiol mainly going to be seen in the reproductive age groups. Okay, estrone is going to be seen after the menopause. Okay, estriol is going to be seen during pregnancy. And estrone is going to be seen during menopause. Okay, menopause. And estradiol is going to be seen during reproductive age group. Okay, adults. Now, what are the different types of androgens that are going to be present? Okay, now let's discuss about the androgens. What are the different types of androgens? You know it, testosterone. Okay, testosterone is the one thing. Second one, the weaker testosterone, are the weaker androgens, I should say. Okay, the weaker version of the androgens are dihydroepiandrosterone. Okay, dihydroepiandrosterone and androstenedione. Okay, androstenedione. These are the weaker androgens and the most potent androgen even than the testosterone, that is dihydrotestosterone. Okay, dihydrotestosterone, which is most potent androgen which is present in the male. Okay, most potent estrogen is going to be estradiol and most potent androgen is going to be dihydrotestosterone. See, first of all, these sex hormones, okay, all these sex hormones, whatever I have discussed, these sex hormones, they are all steroids, right? They are all derived from the cholesterol. Okay, they are all derived from one single molecule, that's the cholesterol. So cholesterol is the one which is going to later turn into androgens, estrogens, and even into the progesterone. All these are the steroids. Okay, so they are steroid hormones, which means they are derived from cholesterol. Okay, so these hormones in the plasma, they are bound with what? In the plasma, they are not circulating freely. Just like other hormones like thyroid hormones, they are also bound with some plasma proteins which are called as sex hormone binding globulins. They are bound in plasma, bound to sex hormone binding globulins. Okay, sex hormone binding globulins, they are bound to sex hormone binding globulins. Okay, so in short we can call it as SGBG, sex hormone binding globulins. And a smaller amount is also going to be bound with albumins. Okay, a little amount is also going to be bound with albumins, but majorly it is going to be bound with the sex hormone binding globulins. See, as they are steroids, right? They are steroids, they are derived from the cholesterol, so they can cross both androgens as well as estrogens I am talking, can cross cell membrane, which means their receptor, the sex hormone receptor, is not going to be there outside the cell membrane. It's not expressed on the cell membrane. The receptors are not cell surface receptors, rather the cell receptors are intracellular receptors. Okay, intracellular receptors, actually they are intranuclear, within the cell also, within the nucleus the receptor is going to be there, intranuclear receptors. So they possess intranuclear receptor. Okay, intranuclear receptor. Intranuclear, it's a better word rather than saying intranuclear. Intracellular will be more better because there are some exceptions. Intracellular receptors. They have intracellular receptors because they can cross the cell membrane. Next point which I want you to know is, sir, I have explained you here, the important concept is they bound to sex hormones within the plasma. Yes, they are bound to sex hormones. Okay. So what exactly is this? They are bound to sex hormone binding globulins. What exactly are these sex hormone binding globulins? So this SGBGs, sex hormone binding globulins. See, they are glycoproteins. Okay, they are glycoproteins. Where they are produced? They are produced in the liver. Okay, they are produced in the liver. So the sex hormone binding globulins, are they going to bind with the androgens or are they going to bind with the estrogens? The sex hormone binding globulins, are they going to bound with androgens or estrogens? What do you think? Both. Bound both androgens as well as estrogens. Androgens and estrogens. But here the most important point is androgens. Okay, androgens, they are bind with more androgens when compared to the estrogens. Their affinity for androgens is much more than the estrogens. Okay, so more affinity for androgens. Okay, of course estrogens are also going to be bound, but more androgens are going to be bound. See, why I am stressing here is because there is some relevance, clinical relevance is there. See, normally when a hormone is free, okay, free hormone, when a hormone which is not bound with any plasma proteins, if it's a free hormone, it is going to exert its effects. Free hormones exert their effects. But a hormone which is bound with plasma proteins, they do not show any effects. Okay, so free form or free hormones, I should say, free hormones or free form show effects. Bound hormones, no effects. Okay, no effects. Now what I want you to know is, because of any reason, okay, because of any reason, later I will tell you what is the reason. Because of any reason, if you increase the sex hormone binding globulins, okay, if you increase the sex hormone binding globulins, what happened to the free androgens? The free androgens are going to go down. Free androgens are going to go down. Free androgens. Okay, free androgens goes down. And estrogens also goes down. Okay, free estrogens. Okay, the estrogens which are in the free form, they are also going down. But important point which I want you to know is, please notice, is the androgens are going much more. Okay, the androgens are going down more than compared to the estrogens. Estrogens are also decreasing, androgens are also going to decrease. But more androgens will go down and compared to the estrogens, which means relatively the androgen to estrogen ratio is going to be altered. Normally androgens and estrogen ratio is, for example, like 1:1 in the free form 1:1. When you increase the sex hormone binding globulins, more androgens will go down and compared to the estrogens, which relatively makes the estrogens greater than the androgens. Okay, so now what happens is there will be amplification of estrogens. So the person is going to show amplification of estrogen effects. So what I want you to know, sir, in any condition, if you increase the sex hormone binding globulins, later I will tell you in which conditions sex hormone binding globulins will go up. If you increase the sex hormone binding globulins, androgens will go down, estrogens will go down, but androgens are decreasing more when compared to the estrogens. So relatively estrogens are going to be more, so amplification of the estrogens effects are going to be seen. Okay, that's what I want you to know. For example, say the conditions in which sex hormone binding globulins are increasing. Okay, and the conditions in which the sex hormone binding globulins are decreasing. In which conditions, sir? See, for example, if you take exogenous estrogens, okay, causes, let me write here, causes exogenous estrogens. Okay, exogenous estrogens are hyperthyroidism. Okay, so exogenous estrogen intake or hyperthyroidism. In this condition, sex hormone binding globulin levels are going to increase. So when sex hormone binding globulin levels are going to increase means there will be more estrogens. Okay, the ratio is going to become more. Okay, androgen to estrogen ratio, the estrogens are going to be more available. So as more estrogens are going to be there, what happens? That will cause gynecomastia. Gynecomastia in men. So in men there will be gynecomastia. For example, if the man is suffering with hyperthyroidism or because of any reasons, if there is exogenous estrogen intake, that causes gynecomastia. That's the side effect. Now, in which condition sex hormone binding globulins are going to go down? You know it, androgens. Okay, androgens, exogenous androgen intake. Estrogen intake increases the sex hormone binding globulins. Androgen intake decreases the sex hormone binding globulins, because when you take androgens, the sex hormone binding globulins are going to go and bind with the androgens, so sex hormone binding globulins levels will go down. Okay, hypothyroidism, and the condition in which the patient is going to lose the proteins out of the body, which is called as a nephrotic syndrome. In nephrotic syndrome, there is glomerulopathy and the patient is continuously losing the different types of proteins out of the body. Albumins, globulin. Okay, one of the globulin is sex hormone binding globulin. The patient is losing the globulins out of the body. So, nephrotic syndrome. Okay, nephrotic syndrome. So, that nephrotic syndrome is going to increase the androgen effects. Okay, when sex hormone binding globulins are going to go down means sex hormone binding globulins is not available, so more androgens are going to be there. So that androgens in females, if more androgens are there means that can cause hirsutism. Okay, so this is the point which I want you to know: sex hormone binding globulin relationship with androgen and estrogen. More sex hormone binding globulins, estrogen effects. Less sex hormone binding globulins, androgen effects. Estrogen effects are gynecomastia, androgen effects are going to be hirsutism. Okay, so this is a point which I want you to know. Next, cirrhosis. Okay, the patient is having liver cirrhosis. See, the liver is a place where the estrogens are going to be metabolized and excreted. Okay, there is breakdown of estrogens, breakdown and excreted in the liver. Okay, estrogen breakdown occurs in liver. Now that liver is gone because of cirrhosis. Now liver issue. Now what happened to the estrogens? What do you think? Estrogens are going to increase. So in that patient who is, for example, because of whatever the reason, if he is having liver failure, definitely his estrogen levels are going to be more. So because of these estrogens, what are the effects that are seen? Gynecomastia. Okay, gynecomastia is going to be seen. So estrogen is going to increase the levels of, or I should say, the estrogens are more procoagulants. It's going to cause the thrombus. Okay, so these patients can have a risk of DVTs. Estrogens, higher amount of estrogen means there is a risk of DVTs. Next, on the skin, if you look, there is a risk that these patients can have, not a risk, these patients can have spider navy. Okay, those spider like veins, dilated veins. Okay, spider navy. And if you look at the palms, there will be palmar erythema. Okay, palmar erythema is going to be seen. In males, there will be testicular atrophy and impotence. Okay, impotency. So all this can be seen in liver failure. So how liver is related with the hormones? How liver is going to be related with the sex hormones? Liver gone, more estrogens. More estrogens, symptoms: impotence, testicular atrophy, DVT can be seen. Okay, spider navy can be seen. All these things. Okay. Next. Already I have explained you, if you increase the sex hormone binding globulins, more estrogen effects. If you decrease the sex hormone binding globulins, more androgen effects. And liver failure, more estrogen effects. Okay. After this, let me discuss about how this reproductive hormones. See, in this video I will be mainly concentrating on the reproductive hormones which are coming from hypothalamus and pituitary gland. Okay, hypothalamic and pituitary gland reproductive hormones I am mainly concentrating. I am not going into in detail in this video about the testosterone and estrogens. Okay, in the male sex hormone I will discuss about the male related things, and in female sex hormones I will discuss about the female related hormones. So this is a basic idea. Okay, now here is the hypothalamus. Okay, hypothalamus, that's the headquarters. Down to the hypothalamus, what do we have? Pituitary. Okay, we are having the pituitary. Now hypothalamus, what it will produce? Hypothalamus in a pulsatile doses, it produces GnRH, gonadotropin-releasing hormone. That gonadotropin-releasing hormone is going to act on the pituitary gland. Now the pituitary gland is going to produce FSH gonadotropins. These are the gonadotropins, FSH and LH. See, these gonadotropins, FSH and LH, are going to be produced in both the sexes. It's going to be there in both the sexes, both males and as well as females. This FSH and LH, they are going to come and act on the gonads like testis or ovaries. Okay, so when they are acting on the testis and ovaries, they will produce male and female sex hormones like androgens. We'll discuss about this in detail in male and female reproductive hormones. Here, this is a basic idea. Okay, testis is going to produce androgens, ovaries are going to produce estrogens. Now, once you have androgens and estrogens, see, these estrogens will always give negative feedback to FSH and GnRH. And these androgens also give negative feedback, means enough is there, no need of extra. Okay, we don't want tons and tons of estrogens and androgens. When you have sufficient amount of androgens and estrogens, these androgens and estrogens will give the negative feedback to the gonadotropins. These are the gonadotropins and gonadotropin-releasing hormones. So this is the basic thing. Next, during puberty, okay, what happens? During puberty, the FSH and LH levels are going to be raised. Okay, FSH and LH levels are going to increase. Before puberty, their levels are going to be less. At puberty, the FSH and LH levels are going to rise. Why? Because it's a GnRH. So GnRH release from the pituitary gland is going to increase in a pulsatile doses. Okay, it's produced from hypothalamus in pulsatile doses. Okay, it's produced in pulses. So that pulsatile dose, we actually need the pulsatile dose, not a continuous dose, but we actually need pulsatile doses. This pulsatile doses is the one which stimulate the pituitary to release FSH and LH. If there is continuous release, that is going to totally alter the entire thing. So we need the pulsatile doses. Pulsatile doses means regular, little by little, little by little. So what I want you to know is the frequency. Frequency, okay, can change the, okay, frequency can change the release of FSH and LH. Means how frequently the GnRH is releasing. If continuously if it is releasing in high doses, then FSH LH actually goes down. If it is coming in pulsatile doses, FSH LH is going to go up. So at the end of the day, the point which I want you to know is the GnRH frequency, how frequently it is coming. If it is coming continuously, FSH LH is going to be down regulated. If it is coming in pulsatile doses, FSH LH is going to be up regulated. Okay, some important points about the GnRH is, see, this GnRH is going to come and act on the anterior pituitary. Okay, GnRH from the hypothalamus. Okay, from the hypothalamus, it will come down. Where it will come down? It's going to come and act on the pituitary gland, right? In the pituitary gland, it is going to act on which cells? Gonadotropes. These are the gonadotropes. So on the surface of gonadotropes, there are receptors. This GnRH is coming and acting on its receptor. Once it binds with its receptor, inside the cell, which secondary messenger system is going to be activated? That's the important point. So GnRH, gonadotropin-releasing hormone, it goes and binds with the GQ receptors. Okay, it binds with the G protein coupled receptors, GQ type. Okay, GQ receptors, and uses IP3, very very important, IP3 DAG, diacylglycerol, IP3 DAG system as a secondary messenger. See, some hormones uses cyclic AMP as a secondary receptors. Now this GnRH, if they ask you in your exam, GnRH uses IP3DAG as their secondary messenger. Okay, done. Now let me discuss some important points about this GnRH. What I have said you is, it's the frequency of the GnRH determines the release of FSH and LH. We have manufactured a drug which is similar to GnRH. Okay, GnRH is equal to leuprolide. Okay, it's similar to leuprolide. Now, what is the difference between GnRH and leuprolide is there is a D amino acid substitution. Okay, here there is L amino acid. That L amino acid, it is substituted with D amino acid. So there is substitution, a D amino acid substitution for L amino acid. Okay, that's the point which I want you to know. What are the important points? What is something better in leuprolide? Okay, what is something better in leuprolide when compared to the GnRH, direct GnRH? Leuprolide is resistant to degradation. Okay, it's resistant to degradation. What does I mean by? You can't break that leuprolide easily. We can't break that leuprolide very easily. So that half-life of the leuprolide is going to be more. Okay, more half-life means better the action. Okay. Now, what else I want you to know is, see, in which conditions we can use this leuprolide? In which conditions we can use this leuprolide is, for example, there is this one female who is having, or I should say there is this one female by 8 years. She have started menstruation. Okay, she have started menstruation. So 8-year-old girl who is going through the menstruation, this is not something good. So now what she is having precocious puberty. Now you have to stop the menses. You have to stop the menses in this condition. So you are going to use the same GnRH analogs like leuprolide. There are other drugs, leuprolide, nafrolin, gosrelin, buserelin. There are even some other drugs which are GnRH analogs. You have to use this drug leuprolide in continuous dose. Continuous leuprolide can be used in the treatment of precocious puberty. Okay, precocious puberty. For the precocious puberty, PP here stands for the precocious puberty. So for the precocious puberty, you have to use this drug in a continuous dose. Why? Because I have said you, if you give continuously, there will be down regulation. FSH, LH goes down. Without FSH, LH, there is no follicle stimulation, there is no estrogen, there is no menses. Simple, as simple as that. Okay. And in what other conditions we can use continuous leuprolide, continuous GnRH analogs? One is precocious puberty. The second conditions are endometriosis. Okay, endometriosis. Endometriosis means what? You know it. It's a growth of endometrium outside the uterine cavity. Endometrial growth outside the uterine cavity, which is going to cause severe spasmodic dysmenorrhea. Okay, severe dysmenorrhea, painful menses. So what you have to do? You have to totally destroy that endometrial implants. Whatever the endometrial implants which are going outside the uterus, you have to just take it out. So for that, what you have to do? See, in endometriosis, there is excess endometrium. Okay, excess endometrium or endometrial implants outside the uterine cavity. So you have to take out this endometrium. For that, what you have to do? You have to decrease the estrogens. You have to decrease the estrogens. How we can decrease the estrogens? By decreasing FSH. How we can decrease the FSH? By giving these drugs continuously. Continuous administration of GnRH or GnRH analogs is going to down-regulate the FSH. So once FSH goes down, estrogens goes down. If estrogens goes down, automatically the endometrial implants what are there outside the uterine cavity are going to undergo atrophy. Okay, so endometriosis we can use, and in other conditions like breast cancer and prostate cancer. See, even in these conditions, breast cancer and prostate cancer, we don't want the estrogens. Okay, in breast cancer, we don't want the estrogens. For the breast, estrogen is the stimulant. So in breast cancer, we don't want the estrogens. So how we can decrease the estrogens is by continuous leuprolide. And in prostate cancer, we don't want the dihydrotestosterone. We have to decrease the dihydrotestosterone. So how we can decrease the dihydrotestosterone? By again decreasing the FSH. We have to decrease the FSH, we have to decrease the FSH and LH. Okay, LH is the one which produces the testosterone. Okay, so we have to decrease the LH. How we can decrease the LH? Okay, this is important. How we can decrease the LH? By giving continuous doses. Okay, so in these conditions, the GnRH analogs are given continuously. GnRH analogs, one example is leuprolide, naphthalene, gosrelin, bostrelin, so many drugs are there. Okay, so this is the point which I want you to know. If you give continuous dose, that will cause a desensitization. Okay, what we are doing is the desensitization of the receptors. So FSH, LH goes down. Now, in which conditions we can use it in pulsatile doses? GnRH in pulses or GnRH analogs, I should say. Okay, GnRH analogs in pulsatile doses. Okay, pulses. Which condition? There is this one female, by 16 years there is no menses. Okay, there is this one female, by the age of 16 years she is not having any menses at the breast development. So she is suffering with what? She is suffering with, the diagnosis is delayed puberty. Okay, delayed puberty. Now for that female, what you have to do? You have to increase the estrogens. Okay, you have to increase the estrogen. So when you give the estrogens, automatically endometrial growth will occur, the breast development will occur. Okay, so if you want to increase the estrogens, what you should do? You have to increase FSH. You have to increase the FSH mainly. So how you can increase the FSH? By giving pulsatile doses. So give the pulsatile doses. So the increase in the follicle-stimulating hormone is going to stimulate the ovarian follicles. So ovarian follicles are going to be stimulated. So the stimulated follicles will grow, they will produce estrogen, estrogen causes the breast development, estrogen causes the endometrial proliferation, you know the thing. Okay, now she is entering into the menarche. So that's one place where you can use pulsatile doses. Where else you can use? See, pulsatile doses can also be used for the treatment of infertility. Okay, for the treatment of infertility. See, this leuprolide, what exactly it is? It's a GnRH analog. Oh, it's a GnRH analog. What it is going to do? If you give it in pulses, pulsatile doses, it increases the FSH, follicle stimulating hormone. So if you give leuprolide, it is going to stimulate the follicles. So more and more follicles. Okay, imagine there is a female who is infertile, she is not getting pregnant. So you can use this leuprolide. It increases the FSH, so that causes a follicular development. Follicular development. Okay, and if you use this drug, okay, FSH is going to increase and LH is going to increase. That LH will cause the LH surge. Okay, that LH surge is the one which is going to cause the ovulation. So basically the point what I want you to know is leuprolide, which is a GnRH analog, it increases the FSH and LH. FSH causes the development of the follicle, LH causes LH surge. Whenever there is LH surge, that's what is going to cause the ovulation. So for the treatment of infertility, you can use leuprolide. Okay. So what else I want you to know is Kallmann syndrome. Kallmann syndrome. So what is this Kallmann syndrome? Kallmann syndrome is absence of GnRH secretion. Absence of GnRH secretion from hypothalamus. So from the hypothalamus, the GnRH is not being secreted. No release of GnRH. So why? The GnRH is not getting released. What might be the reason is, see, from the olfactory bulb, actually, these gonadotropes are those cells which forms, are those cells which secretes, not the gonadotropes I should say, those cells which secretes the gonadotropin-releasing hormone, they will migrate from the olfactory bulb region, actually they will migrate to the hypothalamus. That migration is defective. Okay, so what I am trying to put into your mind is there is a region, okay, olfactory bulb or olfactory epithelium. From this area, actually certain cells will migrate to the hypothalamus. Okay, there will be migration. And in the future, these cells, they will secrete GnRH. So this migration is not occurring. So there is no GnRH. Without GnRH, there is no FSH, no LH. No FSH, no LH. Without FSH and LH, there is no estrogen, no androgen. Now here what I want you to know is, see here I have made 3 arrows for the androgens because this Kallmann syndrome is going to be mainly seen in males. Males are most commonly affected. Males most commonly affected when compared to females. So the patient is going to have hypogonadism. Hypogonadism. Okay, hypogonadism. Because there is no estrogen, no androgen, so hypogonadism is going to be seen. Along with one thing, a patient who is suffering with hypogonadism and there will be defect in the smell, anosmia, he cannot smell, anosmia. So whenever you see such a combination, definitely this is Kallmann syndrome. So low GnRH, low FSH, low LH, low estrogen, low testosterone. Mainly it is going to be seen in the males. So these patients are going to have, because of this hypogonadism, the patient is going to have delayed puberty. Okay, so if you look at the testes, it's going to be small testes. Okay, small testes is going to be seen. Next, what I want you to know is, see the LH and FSH. See, LH, FSH. Okay, these are the reproductive hormones, right? LH, FSH. What is something important? LH, FSH, TSH, beta HCG. What is something common between these three hormones? Beta HCG is seen during the pregnancy, right? And TSH, you know, it has thyroid stimulating hormone. See, all these hormones, whatever I am showing here, they are having two subunits, alpha subunit, beta subunit. Okay, TSH, FSH, LH, beta HCG, all of them are having two subunits, alpha and beta subunits. Alpha subunit is similar for all these hormones, similar for all four. Similar for all four. All four are having the same type of alpha subunit, same structure. Structure is the same. But what is a variable or what is different between these two hormones? It's a beta subunit. Beta subunit of LH, FSH and TSH is going to be different. And that's why see beta HCG, what is this beta? Beta is a beta subunit, or the beta chain is going to be different. Okay, alpha subunit of beta HCG is similar to TSH, FSH, LH, but beta subunit is different. So that's why we are checking for the beta HCG in a normal person. FSH is going to be there, LH is going to be there, and TSH is going to be there. In normal female, these things are going to be there. But what you have to check to know whether she is pregnant or not? You have to check for beta HCG. Why? Because alpha HCG is similar to other chains, all other hormones like LH, FSH and TSH. Okay, so that's what is different. Okay, now all these four hormones, important point is they use only one type of secondary messenger system. Okay, one type of secondary messenger system, that is cyclical AMP. Okay, cyclic AMP. So this is a secondary messenger. GnRH uses IP3DAG as a secondary messenger system, but FSH, LH, TSH and beta HCG, they use a cyclic AMP as secondary messenger system to exert its effects. Okay, so these hormones are going to act on the cell, so intracellular cAMP levels are going to increase. That intracellular increase in the cAMP is going to activate the protein kinase, okay, protein kinase A, that causes the phosphorylation of different proteins. Effects will be seen. Okay, so these are some important points which I wanted. These are the general things. Okay, here I have discussed about FSH and LH, GnRH, FSH, LH, which are similar, which are going to be normally there in both males as well as females. In the next video, I will be discussing about male sex hormones and some clinical correlations and some pharmacological correlations, and in the next video we will be discussing about the female sex hormones and its clinical and pharmacological correlations. Hope the video is helpful. Thank you.